Welcome everyone. Sorry, a bit late. We're meeting on the traditional lands of the Wurundjeri people of the Kulin Nation, and I invite you to join me in paying your respect to their elders, past and present, and perhaps acknowledging that we've still got a long way to go before we have true reconciliation. We've all got a part to play in that. Now, it's an absolute delight to have Andrew Evans here. He's part of the neuroscience juggernaut at the University and the Royal Melbourne Hospital. He heads movement disorders, and he's going to share with us some pretty challenging translational stories about how you take basic stem cell research and stick it into someone's brain. Thanks very much, Andrew.
Thank you, and it's a real pleasure to be here, and also fantastic that I think the WEHI has broadened its scope and starting to harness the wonderful and unique skill set that it has to try and address neurodegenerative diseases, because this is an area that I've been working in now for some 15 years, and I think there's sort of the longer you work in it, the more you realise you don't know. So I'm going to talk about stem cell therapies for Parkinson's disease and touch a little bit on, I think, where it fits in terms of, the therapeutic armamentarian, call it, that we currently have for Parkinson's disease. It's the second most common neurodegenerative disease, and without going into it in great depth, it's probably increasing in prevalence greater than what you would expect according to just the ageing of our populations. So, for instance, and I don't have any data to show, but the prevalence in China has exploded in the last decade as that country's become more westernised. So to some extent, we think it is a sort of Western disease. And while it is the second most common neurodegenerative disease, I think it's different from the most common neurodegenerative disease, which is Alzheimer's disease, in that a substantial proportion of people that we treat with Parkinson's disease have the age of onset younger than 55. Now, Alzheimer's disease, if you have an onset under 55, it's almost always one of the genetically identified causes of Alzheimer's disease, whereas Parkinson's disease, still the sporadic forms of the disease very commonly affect people under 55, so they're still employed, and it has a major impact on that aspect of their functioning, and of course it progresses, as all neurodegenerative diseases do, with time. The lifetime prevalence, about 1 in 40, and advancing age is the biggest risk factor, but it isn't the only risk factor, and I'll talk a little bit about it. So the worldwide prevalence is expected to double within the next 25 years. And so in terms of the health economic costs that we'll be talking about, this is going to be extraordinary. And already the formal and informal costs for Parkinson's care are extraordinarily high and will only increase, of course. Now, this is a little bit of a made-up diagram of the Parkinson brain, I guess, and the yellow blob is the substantia nigra, and the orange blob is the ventral tegmental area. And what's interesting about this disease is even though the disease doesn't necessarily start in these nuclei in the brain, these are the nuclei that are perhaps most affected with regards to the symptomatology that we identify as clinicians. So these are where the dopamine neurons in the brain are. And when you first get the symptoms of Parkinson's disease, approximately 60% of the dopamine neurons in the brain have already degenerated. And I think that's a testament to some extent to the sort of the neuroplastic processes that are able to pick up the slack for this dopaminergic cell loss. It's not just dopamine, though, and I think that that's something as clinicians we sometimes neglect in terms of our assessment of people with Parkinson's disease. All of the monoamine nuclei are affected, but to a lesser extent. So the the noradrenergic locus coeruleus and the serotonergic raphe nuclei in the brainstem are also affected by this degenerative process. And in fact, the current models of the disease emphasise perhaps access points or roles of non-monoamine type areas of the brain in terms of where the disease first starts. And I'm not going to go into the science in great detail, but the areas in kind of very extensive studies done by Heike Braak looking at the pathology of let's call this prodromal Parkinson brain, show that the first signs of degeneration occur in the dorsal motor nucleus of the vagus nerve. And now the vagus nerve is the nerve which obviously connects the brain to the gut, and also the olfactory bulb. So these areas probably are affected by, in the central nervous system, the disease first. And in fact, beyond that, probably also the other nervous system, the myenteric plexus, could be, in fact, the first port of call. And there have been now pathological studies showing in patients who have had, for instance, bowel cancers resected, who've subsequently gone on to develop Parkinson's disease. They've demonstrated that pathological process in the myenteric plexus well before the physical signs of Parkinson's disease have become evident. The neuropathological hallmark of Parkinson's disease is depicted in the figure on the left, and that is a Lewy body, which is an abnormal proteinaceous aggregation. There's a lot of debate in the literature currently about whether this so-called Lewy body, which is rich in the protein alpha-synuclein, represents a toxin. So in itself, it somehow influences or causes the degeneration through, let's say, abnormal aggregation of this otherwise normal protein, or whether it is a kind of tombstone. So this is a kind of stress reaction to a neuronal cell that is dying, and a few of the studies that are currently being looked at across the world, particularly with regards to antibodies directed against alpha-synuclein, exploring the possibility that in fact it is toxic in its propagation, and in some respects has a prion-like effect in terms of neurodegeneration. Well, it's controversial. We can't measure the effects of Parkinson's disease on the brain in any other way other than clinically. And this is something that patients, when they come to see me for the first time, struggle to conceptualise. I think as a community, increasingly Googling our own symptoms, working out how to be investigated for our shoulder pain, and come along with a request for an ultrasound scan, and this is what you've got to do for me, doctor. But in fact, when a person sees me with the signs of Parkinson's disease, there's a number of challenges, and the first one is I don't have a diagnostic test. The diagnostic test is me, and I'm better than a GP, and I've done a couple of studies looking at that in terms of making that clinical diagnosis. But I'm not perfect, because there are other mimics that we encounter in the clinic to Parkinson's disease. One other disorder that's also considered a synucleinopathy, multiple system atrophy, where the synuclein deposition is much greater than you see in Parkinson's disease, for instance, can look exactly identical to the clinical features of Parkinson's when I first see a person. So I'm always, if I'm not sure, I have to be honest and say, I can't make that diagnosis confidently clinically, and we'll have to sort of sometimes let the passage of time tell us what it is. But there are sort of research mechanisms that we can do, and this top right scan is a scan that's not available in Australia, called a DAT scan, which is a SPECT scan binding dopamine transporter receptors on the brain, showing on the normal scan on the left where you get an avid uptake in the striatum, the caudate and the putamen, compared to Parkinson's disease, in which there's an asymmetric loss of dopamine nerve terminals. and that is preferentially directed towards the putamen. And what's kind of interesting is that the stratum itself has a topographic organisation, so it's the tail of the putamen that is particularly involved in motor function for the hand, and so it is typically the hand that is affected first with the typical Parkinson's symptoms of tremor, rigidity and bradykinesia. So these are the clinical signs that I rely on in detecting in a patient when I'm seeing them potentially for the first time to make that diagnosis. And I place some emphasis on other clinical features. Are the signs asymmetric or symmetric? Is there a sort of a potential response, for instance, to dopaminergic therapy with these signs? If it doesn't respond, maybe it's something else. So we have to go through a kind of a little bit of a clinical dance with our patients at the beginning to let them know that Parkinson's disease is a clinical diagnosis. We'd love a test that we could do, a blood test or a brain scan. But even in a brain scan that you can do showing a dopamine terminal loss, as in this with Parkinson's on the top right, you still can't be sure, because these other diseases, multiple system atrophy, progressive supranuclear palsy, delirium tremens, they can all cause scans that look very similar to this too. So there's no diagnostic acuity except to say that the patient has Parkinsonism, which we can detect anyway clinically. Now, the disease processes, or the current conceptualizations of the origin of Parkinson's disease, have evolved over time. It used to be said, for instance, that before, in fact, Maria Spilantini first discovered the first genetic disease, not Spilantini, Polymeropoulos in Greece, that this was not a genetic disease. There were some indicators. So, for instance, people with first-degree relative with Parkinson's disease were known to have a slightly increased risk, but we kind of thought, well, maybe that was just a reflection of shared environmental factors, because we couldn't find at the time any clearly monogenic type factors leading to Parkinson's disease. But since 1998, now 20 years, we have identified some more than 15 genes that are highly relevant to the development of Parkinson's disease. Some of them are inherited in a typical autosomal dominant fashion, such as LRRK2, but they have incomplete penetrance, whereas other ones are more recessively inherited or considered to be, in fact, genetic loci. And I'm not going to go into that in great detail. Probably the two most relevant ones from a clinical point of view are those associated with Gauchers, either Gaucher homozygotes or heterozygotes, and LRRK2. But even so, these genes probably only account for some 5, maybe 10% of Parkinson's disease all told. So they don't explain the majority of the disease. They do perhaps confer an increased risk in terms of young onset Parkinson's disease, particularly Parkin mutations, which is a compound heterozygote typically presentation. But they also look slightly clinically different as well and have a different prognosis. There's also probably relevant environmental factors, and this is thought to be part of the driver, for instance, for this explosion in Parkinson's prevalence that is occurring in China currently. And so it's being, I think now, well established that pesticide exposure, which in particular may be targeting mitochondrial mechanisms, is a particular risk. Rural living, even in Australia, epidemiological studies have shown much greater prevalence of Parkinson's disease in Horsham compared to Melbourne, for instance. And what's really tragic about that is, of course, that it's these people who suffer the most in terms of the access to medical care and specialists like me. And then there are interesting factors that appear to decrease risk for Parkinson's disease, such as tobacco smoking, coffee drinking, and alcohol consumption. And the mechanisms for these are a little bit controversial, but I wouldn't advocate taking up tobacco smoking. In fact, if you have Parkinson's and you smoke, the prognosis is poorer. So once we've established that somebody has a diagnosis of Parkinson's disease, your symptomatic therapies really target the dopaminergic system. So that's the main kind of neurotransmitter that's affected, and there's a fairly kind of good correlation between the amount of dopamine lost in the brain and the progression in these dopaminergic responsive symptoms, particularly rigidity and tremor. Rigidity and bradykinesia, not so much tremor. So we have, in fact, levodopa is our mainstay of therapy, and pretty much everybody who gets Parkinson's disease will be treated with levodopa, a humble amino acid that's found in foods including broad beans. But to get an adequate dose, you need to eat about 3 kilograms a day, which wouldn't be very pleasant. And then there are sort of beans like mucuna pruriens, which is a traditional Ayurvedic therapy, which was used in India some 3,000 years ago, possibly for treatment of Parkinson's disease, that also contain levodopa. And levodopa, of course, is taken up into the remaining neurons and converted into dopamine and improve the symptoms of rigidity and bradykinesia. We have dopamine agonists, and there are pros and cons to each particular approach with regards to the clinical management of someone with Parkinson's disease. MAO-B inhibitors block dopamine metabolism in the brain. COMT inhibitors block levodopa metabolism and increase the bioavailability. And anticholinergic medications, which are hardly ever used, also have an effect on acetylcholine activity and improve symptoms. And unfortunately, we've been using levodopa, or fortunately, for now nearly 50 years in routine clinical use. And it's still the most widely used and best therapy for this condition. So this is somebody who has a Parkinson's disease, and he has a tremor. It's asymmetric, involving the left side more than the right. He's young. When this video was taken, I think 45. The tremor is quite exaggerated in him, involving the left arm and the left leg. And there's, in fact, a sense that he's embellishing the symptoms a little bit, but you can see the movement on the unaffected side is still relatively good, whereas the affected side is bradykinetic, small in amplitude, gets slower with time, and is characterised by frequent blocks in terms of ongoing movement. And you can also see he is a bit stooped, shuffles, doesn't swing that left arm, holds it in an odd dystonically postured type of manner. And this is him after treatment with a small dose of dopamine agonist called apomorphine, which is an injectable dopamine agonist. And you can see in him there's a dramatic improvement in those symptoms. And the issue really is that while you can often get, especially in these young patients, a dramatic improvement in the clinical symptoms with our symptomatic therapies, the issue is that with time and progression in the disease, as the dopamine cells are lost, they become progressively harder to control, and the clinical response to the medication starts to mirror the pharmacokinetic profiles of the drugs that we're giving. So this is in fact, an Australian invention, the PKG watch, which is developed through Professor Mal Horn out of Howard Florey, which is able to measure the degree of bradykinesia in response to medications. And this graph here is an accumulation of 7 days of data depicting sort of, the times from 7 in the morning to 9 at night. And the red lines represent the time that the patient will be taking their medications. And the blue line represents the clinical response, let's say. And you see that when you give the medication, or he's very slow, so the line's very low. The grey line is what's considered normal movement. Within an hour or so, which is about the time it takes to go from the tongue to the brain, you can see normalisation of the movement, The green line here, in fact, represents dyskinesia, or a mild degree of excessive involuntary movement. And that lasts for about an hour before they switch off again and take their next medication before they're back on again and off again. And so the average day for a person with this more advanced type of Parkinson's disease is characterised by symptom-free periods of some 5 to 6 hours per day, with some 8 to 10 hours of very poor quality functioning. So in some individuals, during these so-called, we call them off states, that means their medications aren't working, they can sometimes not be able to walk at all, such that a shopping trip would have to be abandoned. The other issue with these medications that we're administering to our patients, they don't modify the course of the disease. In fact, it used to be thought perhaps it accelerated the course of the disease by overstimulating dopaminergic systems with this toxic levodopa. And it can also exacerbate some symptoms of the disease, particularly autonomic symptoms. So, you know, the disease also involves abnormal autonomic responses. They don't address common and disabling disease effects such as fatigue and axial symptoms. And they are also recognised to cause now more recently issues of behavioural change, such that some patients, after being treated with these medications, can start engaging in destructive behaviours such as pathological gambling due to the unwanted effects on the nucleus accumbens. So we have other strategies, and this is a strategy where, for instance, we are able to target the deep nuclei of the brain with electrodes, implant a pacemaker, and functionally neuromodulate patients so that they can achieve symptom relief with regards to reduction in tremor, improvement in bradykinesia, and rigidity. So this is a patient who is having an awake procedure where we obviously have them unanaesthetised on a table, and we conduct this under kind of imaging guidance there on the right, pass a fine electrode, and we stimulate these areas of the brain, hoping to capture areas that will bring about meaningful relief of their symptoms. And so this is a woman who I did a couple of years ago who's having, I think it'll work. Getting the spinny wheel. Anyway, she's awake. She has a tremor in that right hand, which is quite disabling. And when we turn the stimulation on, the tremor goes away completely and she has normal movement in the hand. But these sorts of things are quite invasive, and they don't stop the progression in the disease either. So they're a very good symptom therapy in some people where the medications are starting to run into difficulties, but they don't fix the overall problem with the disease. I'm just going to skip forward now if my computer lets me. Oops. Scroll ahead. Yeah. So symptom control is not the same as treating the disease. I guess the main challenge now is that a neuroprotective or disease-modifying therapies that can slow or stop disease progression, prevent the development of intolerable disability, I think is the major unmet need in this treatment of Parkinson's disease. And I guess if you look, and I have looked at the literature on the sort of attempts at neuroprotective strategies in the past, they've been fraught with a number of issues. And the first is we don't know what causes the disease, Parkinson's disease. While we have a number of genes that we can identify, they come from sort of, they don't actually tell us what causes the disease, and this is not topic of the talk there, but they give us important clues about perhaps the cellular mechanisms that fail and lead to the disease. The strategies in the past have looked at things like vitamin supplementation, vitamin E, glutathione, antioxidant type therapies. And they're very hard trials to run because firstly the disease is highly responsive to symptom therapies. So when you're measuring somebody from 1 year to the next, the change over time can be indiscernible because you're confounded by having to treat the symptoms of the disease. And also the disease measurement is difficult when you're looking at the ability, for instance, to sustain rapid alternating movements of the hands, which is, in fact, something as a clinician is very difficult to rate. Also, the disease itself, even just changes from month to month, depending on whether there are intercurrent illnesses or other comorbid medical problems that could confound interpretation. I've already mentioned smokers, for instance, having a more progressive disease. The same is true with diabetics. And the other issue is that we don't really know what levers to pull to slow the progression in the disease. Are we just getting, and some of the trials, for instance, one of them was looking at a putative neuroprotective therapy called selegiline as an antioxidant treatment, also happens to have strong MAO-B or MAO inhibition effects, increasing brain dopaminergic levels, and thus having a symptomatic benefit rather than a neuroprotective effect. So you really struggle as a clinician to work out what that neuroprotective therapy could look like and whether in fact you have to be targeting multiple mechanisms in terms of the disease. So a lot of interest in the past, or some interest in the past, has been around stem cells, and there have been trials and challenges, and I'm going to go through them briefly and then talk about what I've been involved in. The first thing, that not all stem cells mean the same things, and so, in fact, many people, when they're talking about stem cells in the lay community, they're often referring to hemopoietic stem cells and immune reconstitution after treatment of, blood-borne cancers. But in fact, stem cells for this purpose can either represent stem cells that attempt to replace some of the lost neurons or support the lost neurons through production of growth factors or neuroinflammatory modulating effects. And they can be derived from embryonic sources, fetal sources, or adult sources. And it's not a new concept, actually. So this is a review that was published a few years ago by Roger Barker and colleagues. And in fact, the first use of sort of stem cell type therapies for Parkinson's disease used dope or monoaminergic cells derived from the adrenal medulla implanted into the brains of humans. And they had some early open label reported successes with these, but subsequently were found to have being not as good as they really were made out to be. Sometime in the 80s, the Swedes in Lund started using cells derived from fetal ventral mesenchymal tissue. So they would use aborted fetuses typically between 8 to 10 weeks of age, and they would take out these sort of dopamine precursor type cells from multiple embryos and implant them into the brains of people with Parkinson's. And they reported some open label, really good responses. And that led to two NIH funded studies in the United States, one run by Warren Olenoff, looking at this procedure in sort of a systematic way in blinded conditions. So they actually did sham surgery on people with who were potentially being implanted with these embryos. And without going into the conclusions in great detail, the trials were were not successful in terms of achieving their primary outpoint, but they did show that there was still a cohort of patients who appeared to do exceptionally well with regards to symptom management, and some were even able to stop all of their dopaminergic therapies, and have excellent symptomatic benefits for many years. And subsequently, since these trials were published, a number of patients have actually gone to post-mortem, and they have shown that in the patients who tended to do well clinically, the fetal grafts were able to survive and produce dopamine. But interestingly, some of them also developed the pathological hallmarks of Parkinson's disease. And to confound the issue further, some of the patients who got no symptom responses, in fact, had surviving grafts. So the problem was that, you know, it was thought to be an issue with application of these technologies, and just going back to this graph, in about 2009, Roger Barker set up the Trans-Euro cohort clinical trial, where they received a very large sum of money from the European Union to try and repeat or replicate these studies and refine the treatments. And they've done nearly 20 patients since this time, but as yet we don't have any publication of results, so we're still waiting to hear how it went. Other cells have been potentially used, but also in other sort of disease process, which I'm not going to talk about. For instance, you know, for amyotrophic ALS or motor neuron disease, there have been a number of stem cell therapy trials reported in the literature. So, the current status of cell therapies involving CNS diseases is kind of complicated, but and there are various pros and cons to various different approaches with regards to the different sorts of cells. And I'm going to talk about the trial that I've done, and look at the sort of the challenges going forward. The drawbacks to the use of fetal tissue I don't have to go into. Imagine finding they needed something like 10 embryos or something per side from aborted fetuses between 8 to 10 weeks old in women who have well-characterised sexual histories and no other infections that could be transmitted, such as HIV and hepatitis. So you could imagine how difficult getting sort of one person treated. And from my perspective, it's ethically controversial, but also kind of, you know, dirty and not going to be practical in the long term anyway. There are 100,000 people in Australia currently with Parkinson's disease. And even if you could treat a minority of people with the fetal tissue here, it's not going to prove a practical approach. So ideally, cell therapy should have high purity, no pluripotency, be cryopreservable, tolerant to implantation, and good availability of source material. There's probably two major approaches that are being looked at the moment, and the first is autologous cell approaches, and this is really maturing. There are two companies out there at the moment. One's called Fortuna Fix, and the other one is called StemLab, I think, which is Fortuna Fix is Canadian and StemLab is Korean. And they're basically taking autologous stem cells, reprogramming them to become dopamine precursors and looking at to reimplant them back into the host. So, and those sorts of cell therapies look promising and probably on the cusp of kind of sponsored studies going forwards. And I'm, again, not going to talk about the exact kind of mechanics of this, but a few years ago now, an American group contacted me to ask whether I would help. And this was because they'd had discussions with the FDA about stem cell studies. Now remember that stem cells were, in fact, it was illegal to be doing research on embryonic stem cells in the United States before 2009. And in 2009, Michael J. Fox in the States appeared before a congressional hearing to advocate for research in this domain. And in fact, many of the conservative commentators at the time mocked him for exaggerating his Parkinson's symptoms and signs while he was appearing before the congressional hearing. But after that time, it was in, I think, January 2009, it became legal. But from one kind of administration to the next, you can't be sure necessarily that is going to stay the case in the States. And the FDA has a very sort of powerful regulatory presence in terms of the conduct of these studies. So they'd had some meetings with the FDA, and the FDA had agreed to working with this particular biotech company, but then they'd run into some significant roadblocks. So this company used parthenogenic stem cells. What they'd done was taken a human oocyte and tricked it into starting to divide or replicate its own DNA. So it had 2 copies, stopped it there, and then chemically treated it to turn it into what is now a neuronal precursor, and developed a master cell bank. And then, and I think in some respects it bypasses this somewhat ethically tricky issue of using embryonic stem cells, which in themselves could be potentially used to, grow, fetuses or life or tissues. So you have to be a little bit careful. But these parthenogenic ones are, I think, ethically a little nicer. And they've done quite a lot of preclinical work looking at implanting this in preclinical models. And these kind of neuronal progenitors were shown to be able to differentiate in both rodent and subsequently non-human primate models into a range of neurons, of which about 2% were dopaminergic, but also have effects in terms of sort of neuroinflammatory modulating effects and producing neuronal trophic factors such as BDNF. So this is one of the studies that was early reports showing that the particular parthenogenic stem cells that I'm going to talk about in humans were capable of differentiating the dopamine neurons, expressing the standard proteins that you see, tyrosine hydroxylase, FOXA2 and so forth, and DAT, and they can secrete and fire, dopamine and fire action potentials. They were also able to demonstrate that this was able to be done in 6-hydroxydopamine lesioned rats, and were able to replicate the findings in MPTP lesioned African green monkeys, and at the same time show that there were relevant behavioural effects too, so that the degree of Parkinsonism appeared to be improved in monkeys in which the stem cells were implanted and differentiated and survived. They also proposed that there could be neurotrophic support factors, so they showed increased levels of neurotrophic cytokines, BDNF, GDNF in vitro, thus potentially increasing the survival of dopamine neurons. So with that kind of, without going into the whole kind of preclinical sort of portfolio, we went to the Therapeutic Goods Administration in Australia, who'd just recently made a statement supporting the kind of use of stem cells to treat human disease, and so that was why kind of Australia was considered for this sort of study. And the process involved a couple of preliminary meetings with the TGA. I flew up to Canberra a couple of times. And the TGA also had to be flexible because they'd never had an application for a stem cell study like this in human beings to consider. So they had to develop, I guess, a committee and a process of evaluation and also bring in the right expertise. So there were something like 28 people on that committee with all sorts of areas of expertise and interest, from pharmacologists, stem cell scientists and haematologists and all sorts of people. And the process involved what's called a CTX application. Now, the CTX scheme is an evaluation process that involves the review of the TGA of relevant but limited scientific data, which may be preclinical or early scientific data prior to the start of a trial. And the primary responsibility of the CTX scheme is to review the safety of the product. Obviously, the local ethics committee is involved, has to then weigh up the aspects of safety against the potential for, let's say, benefit. So the ethical and scientific issues are a separate issue. And obviously the conduct of a clinical trial under the CTX scheme must be approved by the responsible HREX. And this involves also things as straightforward as, you know, what needle I'm going to use to inject the stem cells into the brain of the human being, and whether this is an approved product in Australia or not. So the process is you have to sort of has to be fairly mature in your understanding of the logistics of this before you actually go to the TGA, and they consider all aspects of this with that view about safety. So we first started that made our first submission in August of 2014, and they developed a kind of a list of questions for us, which we went away and developed sort of responses to, and then met with them again. But they appeared overall sort of positively disposed towards proceeding with the trial, condition on answering a number of these kind of questions and queries. And eventually, some 20 months later, after our initial sort of application was made, we had approval and sufficiently answered all of their questions. Then this resulted in a proposed phase 1 open-label single-arm dose-escalating study involving 12 patients, divided into 3 cohorts: low, medium and high dose. And when you're a clinician involved in this kind of treatment space, it opens you up to sort of, you can't concentrate solely on the science or the patients. So what happened was that we had the first patient literally online following us, asking for updates, and he's like first cab off the rank after fulfilling all the study criteria. But the second patient, when he came to have his implantation, said, "Oh, is it okay if I bring Channel 7 along with me?" And I'm like, no. And he's literally got them booked on the flight to come the day of implantation. And I was like, this is not going to happen like this. And he's going, well, I've already spoken to them. They're going to run the story, whether or not they get their intraoperative footage or not. So I had to kind of develop a strategy to mitigate that problem. And that's the last thing I want is to not have control. I actually went back to the ethics committee and said, what do I do? And after discussing it with them, we decided to make a public announcement about the trial, which hitherto had not been mentioned in the media. And this is what results, if it works. Anyway, I don't think the video is going to work for whatever reason, but that's Peter Hitchener on the Channel 9 News talking about our study, and the excitement of a possible cure for Parkinson's disease, and of course the phones run hot for the next 6 months. The oversight, well, the preclinical studies were conducted under GLP. The trial was sponsored by ISCO. I have no conflict of interest. I have full rights to publish. There's an independent data safety monitoring board. It's approved by Melbourne Health Ethics Committee. The CTX application was approved by the Therapeutics Goods Administration. And of course, the trial's being conducted according to GCP guidelines, overseen by Neuroscience Trials Australia. So, you know, I think all the boxes are ticked there. This is the outcome testing, and obviously this is kind of exploratory. The phase 1's trial means we're primarily interested in safety issues, but obviously we want to explore the possibility of an efficacy signal, and the dose. I'm not going to talk about the reasons for the different dosing strategies that we used, but when we went through the CTX application, the TGA actually discounted us in terms of the number of cells we could implant, and there's obviously issues. Putting cells into the areas of the brain that need it is not easy, and we had to develop a whole new strategy around that. When you're so this is an MRI showing our preoperative targeting for implantation of an aliquot of cells into the substantia nigra. That's really deep down. It's like hitting a pip in the middle of a grapefruit without cutting it open. And this was the day 1 post-operative scan. So here's where the cells were targeted, and here you can see a tiny faint little dot there using the eye of faith of where we drop the cells, and hopefully they're going to do their magic. So the progress to date. Well, I don't have a final analysis. The last patient was implanted March of this year, and we have sort of an intensive follow-up for a year after implantation of the cells, but he's now at the 6-month follow-up. The mean age of implantation of the patients was approximately 60 years compared to the average age of onset for people with Parkinson's, 64. So this is a younger cohort of people, and the disease duration was 6 years. So obviously they're sort of 54, 55 years old disease onset age. And the clinical sort of measurements we take, the UPDRS, which is one of the typical scores, show that they are very responsive to their levodopa medications. So they get a good dopamine response. If we can therefore increase the number of dopamine cells in the brain, then we would expect a clinically meaningful improvement in symptoms. 10 have now reached 12 months since transplantation. And there's been some expected, unexpected serious adverse events with 2 patients having post-operative seizures. One had actually had pre-operative seizures but failed to disclose it because he knew that that would exclude him from being eligible in the trial. They're, you know, patients are patients. One's had a fractured hip and one's had a pneumonia. In fact, recently one's also had normal pressure hydrocephalus, which is not on that list. There's no evidence of any tumour formation on serial MRI and no off-period dyskinesia. I forgot to mention that the fetal nigral studies, the patients who were transplanted, some of them developed excessive dopamine release in the striatum, causing abnormal involuntary movements despite medications. And a few of them had to have their transplants selectively debulked, so, you know, resurgery to improve that situation. I have looked at the 6-month post-transplantation figures, and patients in an open label fashion have reported improvements in their symptoms. Quality of life scores have improved across the 12 cohort. Obviously that's contaminated by you know, placebo or expectation effects. And we've been doing, and I showed you a graph, that PKG objective measurement of Parkinson's symptoms. And I was able to sort of pull these out last week, showing that the bradykinesia score, higher number is worse Parkinson's symptoms. The bradykinesia score has trended downwards over 18 months in the patients in whom data was available. we're doing dopamine PET scans over at the Howard Florey, and of course these sorts of things don't happen without a team of individuals, and this is what theatre looks like with people who are helping in terms of adequate targeting localisation of the implantation sites. A stem cell scientist, Emma Brain, who has moved in since to the Alfred Hospital. The surgeons and the theatre team have been fantastic in giving up their weekends to help out with this, as well as Mr. Girish Nair, the surgeon, who ultimately the buck stops with him if something goes wrong. So thanks, and I'll take questions.
Thanks, Andrew. Does anyone want to open the account? We've got one here. I don't know if this is working. You might need to shout it out.
So, Andrew, post-surgery,
Yep.
assuming the neurons all differentiate into what they're expected to, what do you do to, or what happens for restoring, like, the proper neural connections and all
Well,
that
that's
basic for movement?
That's one of the big issues. So with the fetal nigral studies implanted directly into the striatum, and that's actually where that's where the dopamine projections go to, but not where the dopamine cells live. And so one of the problems they experienced in that study in a small cohort of individuals was runaway dyskinesias. So they got excessive dopamine that wasn't under normal control. Whereas the substantia nigra has a lot of kind of reciprocal connections with, very different areas of the brain, cortical even, that presumably help modulate the dopamine release. So that's why we were keen. In fact, I implanted the striatum as well as the substantia nigra. The fetal nigral cells don't migrate. You drop them there, they don't move. The dopamine precursor cells, you have to target. Whereas these ones actually, because they're in fact not dopamine precursors, they're neural precursors, migrate a lot more readily, up to centimetres, and that was established in the preclinical works. But the hope is that by kind of targeting as well the substantia nigra, that it might provide a more kind of physiological kind of networked type of function.
This is a continuation of that question. Well, what other cell types do you get? Do you get a whole lot of astrocytes?
Yep. So I think from memory it was other neurons, non-monoamine type neurons, astrocytes. Some just hang around and don't differentiate. Some die. And that's why in fact the sort of through the for instance glial-derived neurotrophic factor implies that you're getting glial cells being produced out of this aliquot, and to some extent this may be a strength but also a weakness of the technology, because you're not necessarily going to get as pure a dopaminergic treatment as you would with dopamine precursors. The standard for stem cells, if you're looking at dopamine precursors, is apparently around 80%. You want 80% to differentiate into dopamine cells, and in the sort of the studies and the modelling that's been done, you need about 100,000 or more to differentiate into dopamine cells in the right spots to potentially to see a clinically meaningful effect. So this, maybe we need in these sorts of treatments a kind of a lattice arrangement that will help the cells more preferentially differentiate along dopaminergic pathways. Maybe if I implant the cells into patients with a more severely damaged substantia nigra with fewer dopamine cells, the microenvironment is not going to be as conducive to dopaminergic cell differentiation.
We might wrap it up there. We've got one more quick one.
Are you looking at ways to modify the cells that you're implanting to kind of protect them from getting Parkinson's?
Yeah, it's thought that in the fetal nickel studies that's probably not going to be a big problem. So there's something like something like 5% will be affected by the process in like from memory in sort of 5 or 10 years. So it's not a big. But you're right. I mean, you're implanting into a disease state, and that I'm not stopping that. So, you know, you may also need, even if you get a treatment response, you might also need neuroprotective type factors going on there to be really successful. So, and the TGA actually stipulated that we needed to follow these people up for 6 years, which we're trying to do. The trouble is they keep moving around. I've got one in Western Australia, one in Sydney, one in UK.
Thanks, Andrew. That's terrific.